Welcome to Boundless Potential, how unlocking big data can change health. As Anish mentioned, I am Dan Diamond. I'm with POLITICO. I'm a healthcare reporter there, writing the Pulse newsletter and the Pulse Check podcast. And I'm joined by 4 experts in big data as we attempt to unlock it and solve all of the challenges therein this morning. I want the panelists to speak for themselves, but a question that I've been grappling with, I feel like I've been sitting on panels like this, asking questions about how big data is going to unlock healthcare for years, sometimes with the same people I'm sitting next to now. So while I have a question for the panelists, I want to ask the room first. Big data, hype or reality? If you think it's hype, show of hands. Two lonely folks. Maybe reality.
You voted.
And then both.
Yeah, both.
Yeah.
Neither. Opportunity, right?
Oh, well, we'll start with Murray Aitken, who will give a quick description of what he does and how he sees big data, and we'll kind of move down the road from there.
Sure. So I'm with Quintiles IMS. I lead the Quintiles IMS Institute. We're a small group within the large company that draws upon all of the resources, the data and expertise we have within the company to undertake research we put into the public domain on a range of issues. You want me to answer the question? Or?
Please, yeah.
Sure. I mean, so I think what we observe in terms of the progress on big data is it's real, it's here. It's not as much as we might have anticipated 5 years or 10 years ago. It's not as much as the hype would suggest, but it's definitely having a meaningful impact. I think you can see that in terms of drug discovery and development. We can see the fullness of the R&D pipeline, and part of that, a good part of that, I think, is related to what might fit under the umbrella description of big data. We're seeing clinical trials become more efficient and faster, and part of that is because of the way in which big data can help identify site investigators and enroll patients faster. We're seeing big data being used to help get the right patient the right drug at the right time. So again, we've still got a long ways to go, but we see progress. We see progress there, and I think big data is also being very helpful in raising the bar in terms of requiring everyone in the healthcare system to demonstrate that they're providing value for the money. And that includes on the life sciences side, but in other parts of healthcare
Murray,
as well.
you mentioned that we are not as far along as one could have expected X number of years ago. What has been the biggest barrier from your perspective?
Well, it's more complicated. It turns out, humans are complicated entities, that the data that we collect is episodic and incomplete. And it's often, and even the data we're collecting is relatively dirty and has lots of gaps, and there's lots of NLP requirements and so on. So just getting access to that is important, and then figuring out what it all means is also a challenge. The biggest challenge, though, is still, even when we know what it means and what it says and what it suggests, as we've heard already on the panels, does that actually get translated to something that moves the needle from a performance and action perspective?
Anish, take the baton from there.
Well, the reason it's, and I thank you for the chance to say a few words. My background is in policy. I was the president's chief technology officer in the Obama administration, and I come at this from the perspective of the broader system gap. And before we judge whether we've had the value of big data, you need to first assemble the feedback loop to train, to be the source of training. So in healthcare, unlike an e-commerce website, in an e-commerce website, you have a link that tells you how you came to the site. You can track all the clicks the patient or the consumer had while on the site, and you can determine whether they bought or didn't buy the good. All of the data and the feedback loop is in one environment, so the newer tools that we call big data can help to understand what are the mechanisms that drove someone from considering buying a good to buying a good. In healthcare, we have small, unlinked data. So the problem at the front end is to connect the small data sets. You see a doctor, they treat you, and document it. You go to the hospital, they treat you and document it. You take a medication, the pharmacy has it, and the orderer does. So our challenge right now is to assemble the feedback loops in such a manner that then could take advantage of these tools that hold promise. Look, the way to measure whether we need this or not is pretty straightforward. Are patients in the healthcare delivery system getting the care that they deserve? Are they getting care they shouldn't be getting? And could they be getting the care they need in a more cost-effective way? We don't have answers to these three questions today. Simple stuff, Dan Diamond, is falling through the cracks. Here's a small example. We know as a society that a patient, when they discharge from a hospital with some severity in their condition, could benefit from some consultation to make sure their transition to the home is a good quality one. Society not only understands this, but is rewarding doctors to spend a half an hour listening to the patient's concerns after they've discharged and work them through a transition process so that they can avoid both getting readmitted or having a deteriorating effect. What percentage of doctors today perform these transitional services for patients who are eligible for them in the Medicare program, where it's paid for? Dan Diamond.
You're asking me, I'm going to assume it's a small percentage.
That's the point. It is probably, in this environment, under 15%.
We did not work this out beforehand.
But here's my point. I don't need a predictive model, machine learning algorithm to tell me that when I discharge from the hospital, my primary care doctor, who's going to get paid a couple $100 if I'm sick, to explain my discharge notes to me in a way that keeps me healthier over time. If we can't get these basic, proven techniques adopted in healthcare, we've got a lot of opportunity before we take it to the next level. This is the joke of low-hanging fruit that's so low we're stepping on the fruit on the walk down the street.
And slipping on the banana peel.
That's right.
I have questions for you, but I think we should keep moving down the panel. Marty, you've seen this from a longer perspective of being with the cancer group started by George H.W. Bush. Yeah. How has big data evolved, or at least the way that it's thought of and treated here in Washington, D.C., looking at this market over the past 25 years?
Thanks, Dan, and thanks for the opportunity to introduce, at least to some of you, the CEO Roundtable on Cancer. That you're right, the 41st President of the United States, George H.W. Bush, founded many years ago. And it was just a vignette there. As some of you may know, their second-born child, Robin, died weeks short of her 4th birthday of leukemia. And the Bushes, Barbara and the boss, elected for reasons that were very privy, not to bring her death into public view, only because it would have been perhaps misused as public chattel. In their private life, that unrequited need was to be fulfilled, at least in part, when he reached out and said, "What is corporate America? No, what are executives in corporate America doing about cancer?" And the answer was, we're writing checks and we're running marathons and all sorts of wonderful eleemosynary things, but did they own a piece of the action? Did you actually have an opportunity to participate with something you would do? And the answer was, gee, they've never been asked. And so it was that this group, this CEO Roundtable on Cancer, was created. Some of CEOs across all industries. And if you are not members, you should be, and I'll help you be. Sometime later, the boss is there and he looks out at the CEOs in this room and he noted, as we pointed out, that there was a subset. CEOs of big pharma, top-tier biotech, CROs, your original founder, and a computer company or two, and he said, you're missing a bet. And he was right. If you calved off this group of CEOs under the rubric of the Roundtable and gave them the same charge with which the Roundtable was originally formed years before, what was that charge? Be bold and venturesome. No hype, but provide hope that's evidence-based. If you did that, maybe they'd respond. And so it has come to pass, Dan, that this, quote, group, the Life Sciences Consortium of the CEO Roundtable, populated by CEOs of those entities, came together and said, the boss put us here to be bold and venturesome. And a number of things took place, but cutting to the chase, 8 years ago, one of them said, how about sharing our clinical trial data? The room not only went silent, it went cold. And then this person, who will remain nameless except hereafter, because he is guaranteed a higher place in heaven, said, and I quote, if not now, when? And ended it as if to say, think of all those volunteers as cancer patients who volunteered to join a clinical trial. What was their intent? To have those data held private, or to make certain that it helped somebody, even if it didn't help them? That became Project Datasphere, and I'll tell you about that in a moment.
Well, it's very hard to follow at first. But we just came out of an administration where President Obama, Vice President Biden were grappling with many of the same things. Biden gave several speeches about how there wasn't sharing of data in the cancer space. So for all of the work that's been done, it seems like not much progress was made.
Isn't he a good reporter?
Well, I'm not supposed to be swayed by the emotional story. I'm just trying to get.
And so, the 41st President of the United States wrote a letter to the 47th Vice President, Joe Biden, and said, Joe, here is something that we've been working on for quite a while, remembering that they both lost children to this disease. Beau Biden had just died a year before. And the president said to the vice president, if there's anything we've done that can be of helpful to you, let us do so. And he gave the letter to me, and I acted as an emissary and hand-delivered it to the vice president. There's another story that I won't take all of our time with to let you know why these two fellows over more than 40 years have been close friends, although always on different aisle seatings. The vice president said, this is what I've needed. And he went on the stump at the ASCO, at AACR, wherever there was a microphone, and he's never found one that he doesn't like. He said, what about these silos? Break them down. At the time when he started, there were 22,000 cancer patient lives in this thing called Project Datasphere, which is open access. Everyone here, projectdatasphere.org, 48 hours, you will have the keys to the kingdom. Less than 25.
I see people going to their phones right now.
Please, less than 25,000. We just crossed last week the 100,000th patient. It's now the largest cancer clinical trial open access repository in the world with SAS tools, all of SAS analytical tools, $41 million worth of developed tools, free of any charge. So is it a library? It's a digital library, the biggest. Is it a laboratory? It's got the tools, the analytical tools, and it has the reagents, the data. And from that has derived what? 11 major publications, Nature, New England Journal, 2 in Lancet Oncology, so forth and so on. If that's not proof of principle, from what? From the data. Very often comparator-armed data in cancer clinical trials that's been sitting there on hard drives, not only in industry, but also in academia. And it's now coming in.
There's one more panelist that we need to hear
Please.
from, and that's Robin Thurston, who runs Helix, which is a different way of looking at big data. You're going after the consumer directly. Can you talk a little bit about how you are doing that and your perspective on that original question, lost now from 10 minutes ago, but hype versus reality, especially in the consumer space with respect to big data?
Sure. So Helix is a first of its kind consumer genomics platform. We were spun out of Illumina, primarily with the goal to empower consumers to unlock their DNA in a whole bunch of different categories like ancestry and in health and in fitness and nutrition, other categories. And I think some of my experience comes from my previous company. I've been at Helix for about a year. I founded a company called Map My Fitness. Very much another big data challenge. 50+ million consumers. Today, even at Under Armour, and now I think total with MyFitnessPal, there's over 220 million people on the platform. And I think about data. There's so much of it in many respects, especially on the consumer side. These phenotype databases are larger than they've ever been in human history. I mean, as an example, MyFitnessPal has the largest database of food preferences in the history of mankind. I mean, there is no data set bigger in understanding what people actually eat. Not what they bought at the grocery store, but like literally entering what they've eaten. And I think that the challenge, though, is that how do you then interpret that? And I think the shift that's coming is not only in the completeness of data. So a lot of these big phenotype databases are definitely episodic. People sometimes are logging and sometimes aren't. Although there is a subset of users who literally never forget anything, whether it's food or it's fitness or it's sleep or any of these things. There's literally people that are what I would call the true quantified self people that literally never miss one thing, and there are millions of those people. But largely it's episodic, and I think the next wave is not to unlock truly big data and almost the results, like how do you get to the benefits, is going to be in having actually a smaller subset of that data that is actually more complete. And I think the companies are going to start focusing on this, because the issue right now is not the data sets themselves. They're too big. They're almost, in many respects, too big to analyze, too big to really figure out what subsegments you're going to go after. The companies that own them don't necessarily have the best data science groups. They aren't necessarily making them public. So I think there's a little bit of a switch coming to almost smaller populations, but much more complete data sets that are going to be very well examined and probably very public from a research perspective.
Robin, I'm thinking, hearing you speak, the four of us on this side, we've been in healthcare basically our entire careers. You've been outside of healthcare, and you're coming into this space having worked on big data sets in other industries. If you had to grade healthcare on its use, on its application of big data, what would you grade it?
Be careful.
Yeah, be careful. I know. Yeah.
No, don't be careful.
Yeah,
Be
I
honest.
think the really big challenge is, we had a lot of great partners even when I was at Under Armour prior, MyFitness, people that I really felt like were making major investments in how to improve it. The reality is that everybody in this room, like, your bar for a great application these days is like, will Uber pick me up in 4 milliseconds on the corner, like, of this exact street and location? Like, that is the expectation in this room. And unfortunately, healthcare is not even close. Like, it's not even, it has so far to go to get to that moment where the interpretation and the result back to you as a consumer is so immediate and instant that you have this delight experience. That's the right word. I think it's like it's a magical moment for you as a consumer. Healthcare's got a ways to go, and I think that I do believe people should be excited. I heard someone say it the other night, like, I think that you have to look at the companies that know how to do that best, I think, to potentially really make a seismic change in the experience. I'm not going to talk, that's less about the data and the research side and more about just how do you make it magical for you from end to end, everything, whether it's how do you visit the doctor to how do you get money back, to your co-pays, to all of those things that transact while you're going through your healthcare experience are they're not the best consumer experience in the market, and everybody in this room knows it. The best ones are look on your homepage on your phone. Like, those are the ones, because those are the ones you keep going back to over and over and over.
Politico's on my homepage, yeah.
Yeah, I would just add that I think
Great experience, by the way, great.
I would just add that, I think when we talk about unlocking big data to change health, it's useful to be a little more precise about which part of the health issue we're trying to solve. So, are we focused on the 5% of the patients who consume 50% of our healthcare?
You can drop the mic after you make your.
Yeah. 50% of our healthcare resources, are we focusing on wellness and prevention? You know, a lot of the people who are diligent in entering everything that they eat and have their Fitbits and so on, you know, these are probably people who would otherwise actually be in the segment of the population that actually consume, you know, no more than 5% of our healthcare resources. Again, it doesn't dismiss the importance of this from a prevention and wellness perspective, but we've got big issues already in terms of where our healthcare dollars are being spent and where our resources are being deployed, that I think, you know, it's important to keep a focus on that, and how can big data help to solve those issues.
Let's get to some of those issues. So opioids, for example, a big focus in Washington, D.C. this week with President Trump moving to declare a national emergency. How can big data be helpful in combating the opioid issue? And that goes not just for Murray, but anyone on this panel.
Let me take a stab. I mean, herein lies the opportunity and some of the limits in one conundrum. An individual has pain, and they look to treat that pain. And they enter the healthcare delivery system at various points where we'll see a variable response to how to treat that pain. In some clinical environments, there might be a fuller assessment about whether or not you might be predisposed to potentially become addicted to these therapies. And so there might be a default to start with the alternative methods. And in other cases, it may be just without regard to some of the context for your propensity, you might find yourself with an oversupply. You know, you might have a minor issue, but you've been given a potential to reorder a medication for many, many days. The variability with which the system will treat the person who presents with back pain is off the charts. Now, the theory behind big data would be, if I presented, given who I am, people like me should receive the following therapy to tackle the issue of pain while minimizing the risk of my being addicted. And we have countless use cases in the internet economy where we've solved similar questions. I show up, I take a photo. There's more talent in our economy focused on predicting what elements of our photo will be most appealing to us. Honestly, great for us, for our families, and wonderful that the machine learning experts have figured out that if a person took a panel shot right now, they could determine it's in the Ritz, in DC, by the backdrop, at a Milken event with these folks, all predefined. Yet the same snapshot isn't, I walk into the ER concerned about my pain. Let me tell you all about me, who I've come from, where I live, the propensity to have issues. And that's the gap. So the tools exist in the society to run the data against these models, but we just haven't organized the system by collecting the data and incentivizing folks to look at it in that way to deal with the issue of, I got to solve my pain problem. Don't just tell me I can't have the drug. Tell me that I need to have an alternative that works for people like me.
How do we incentivize people in ways that haven't been tried yet? It seems like there are plenty of dollars. There's legislative interest in moving after this space.
And we should have this conversation. My point is, the arc is clear. We are going to reward financially organizations that can reassemble the delivery system to actually achieve the outcomes that we've just spoken about. The problem is, it's a slow pace to that end state, and we're in a bit of a transitional period. So maybe 5 to 10% of a doctor's actual take-home pay is tied to rethinking whether he's or she is personalizing or performing based on the needs of the individual. And 90% is, well, I got to see this patient every 7 minutes to keep up with my overhead for the practice. So as the shift to payment on this value curve gets to be a higher proportion of my take-home pay, it will bring the delivery system, it'll incentivize the system to organize around it. Meanwhile, in parallel, Dan, we do need to find a simpler method of stitching together the data. I'll maybe use this as a handoff to Martin. Your story was really moving, and I'm very keen to learn more about the program. I presume an option would be consumers would have the opportunity to assemble their records and deposit them directly into the data sphere. And that bypasses the need of other folks having to choose to join. I can choose directly as an individual. That's our legal right under HIPAA, and the emerging technical requirements imposed on the doctors and hospitals for healthcare IT systems should allow for it. So we will both need to increase liquidity of the data so you can link small data sets and incentivize the delivery system to bring these tools to life.
Marty?
Let me give you a bit of granularity. This is really powerful, but let me just take it down maybe an octave, because I want to make certain that we're here speaking to your original question, Dan. Is it hype or hope, or really is it helpful? And it's in keeping with this Milken Institute, of the Future of Health Summit, that I really, in a sense, quasi-announced this, because it was at Michael's home in Tahoe years ago where he held a summit on innovation, and some of you may have been there. It was a really marvelous moment for me to have been invited. I was sure there was supposed to be a different Dr. Murphy. That's why I went to every session, because I didn't want the other guy to come in and sit in my seat. Clearly, I was not in a class.
That's actually how I got through college.
I was looking in your paper.
Yeah.
So, where this thought came to pass, let's take clinical trials. Let's take cancer clinical trials. We're taking it down now to this principle. You have a drug, there's going to be lots of effort, enormous amounts of money, and tremendous time, because that drug has to go into patients with this disease, and then patients that are very similar are going to have a comparator, standard of care, that does not ultimately increase overall survival. That's why you're doing the experimental. So you have double of everything, at least, in a 2-arm trial. And if that's a rare event, a rare cancer, let's say, and the more we learn about genomics, the more rare the tumors are. There is no longer lung cancer. There are subsets, genetic and genomic subsets, that make these individual types of lung cancer rare. All of a sudden now, if you're sitting in a pharmaceutical boardroom deciding on where you're going to place your investments, well, you're going to go with the larger numbers, because the probability is that one might actually be a drug that actually would be useful, and we could return part of our investment. Now, we're a nonprofit, but we don't get anything without them. So the question was, could we, with data, with good data, Dan, not only big, it's got to be pure, it's got to be really excellent clinical trial data, could we actually test the system and ask the question, do you really need to randomize patients onto the comparator control arm? First page of the New York Times some years ago about those two cousins. One got randomized in a malignant melanoma trial to the experimental, and not only survived, went into remission. The other got randomized into the comparator arm and died in 6 months. Remember that? Can't we test that? Well, at this time, we're going to tell you that the FDA, let's catch them doing something right, and this is brilliant, said to us, Project Datasphere, in the last 20 years, in a type of lung cancer, yes, that is rare, called small cell lung cancer, in small cell lung cancer, in the last 2 decades, there has not been any increase in overall survival despite the 57 small cell lung cancer trials that have been executed. In all of those trials, the same 2 drugs were used in the comparator arm, etoposide plus a platinum base, cisplatin, carboplatin, whatever. All of those patients in the comparator arm, they did not survive either, of course. And the experimental didn't increase their overall survival. FDA says, if you can capture, and we're going to do so with Quintile's IMS help, those 57 comparator arms in those trials, make sure that it's really good data. Now, curate it, which is a great word. It means janitorially clean it up. So you're all speaking the same language. You curate this data, and now make it into a synthetic comparator arm, but a big one. 57 comparator arms now into one. Then the FDA will go into Project Datasphere and pressure test that synthetic comparator arm. And if, as they predict from the numbers, it's going to be found to be robust enough, the oncology branch, that is the Oncology Center of Excellence, created by the 21st Century Cures Act of last year, thank goodness, they're going to release a guidance that says, if you have a drug which you believe may be effective in small cell lung cancer, you no longer have to randomize patients onto a comparator arm. Refer to the robust historical data set in Project Datasphere. Take all your patients and put them on the experimental. What will that do for industry? How many more drugs, good possible drugs, are going to be said, well, let's try small cell lung cancer? The time is half. We don't know exactly how much half, but at least 50%. The cost is going to be at least 50% less. You're going to know sooner. Patients will finally, I predict, from this meeting, when all this is done, in small cell lung cancer, we'll see the first uptick in overall survival lengths as a consequence of using old data in comparator arms, but good data, cleaned up and made openly accessible.
That's terrific.
That's progress.
I can't clap because I'm holding water. Robin, I'm curious, we just heard about cancer and the opportunities therein to solve. You are working with genomics and see opportunities in the healthcare space. We talked a bit about opioids and applying big data. What do you see as some of the either low-hanging fruit or fruit that's so low that we're stepping on it in terms of applying genomics and big data to solving those problems?
Well, a lot of the data sets right now very much come from people that are already sick, right? So I think there's enormous opportunity in understanding these diseases with the healthy population. And to some extent, all of the partners we're working with, the Mayo Clinics, Geisingers, and Vitae's, it's a change in many of their business models to go to the healthy population. But there's so many benefits. One is I think it will help research overall as those data sets are merged with the sick populations in understanding. I think secondarily, I think there's a societal benefit, which is that people that know much earlier in life that they have some predisposition, I think will take action on that in ways that will extend their life dramatically. So, if you talk about something like the Lynch syndrome, like basically, as an example, if you know that in your 20s, your sort of follow-up and procedure is so much different than if the first time you go for a colonoscopy, you have something, and then all of a sudden they identify that you had Lynch at 45. Like your entire life could be changed on that event alone. And so I just think we are moving on the consumer side towards, I believe, consumers having a much better understanding of their health in general. And that, I think it's going to be very, very powerful for, many healthy people around the U.S. and globally to have this information at a much, much younger age.
Well, I am recalling what Murray said about the patients who actually present the most cost and challenge, and whether those patients can be easily activated by access to data, genomic, whatever it might be. How do we cross that chasm?
Yeah, the more expensive, cost to the system. Clearly, I do think, specifically in genomics, the cost is going to come down there too. There is a trend. To have your genome run 10 years ago, I think Jay Flatley told me his was like $50,000 or something like that. So, it's clearly evolved quickly in the genomic space. I think that. I think all of the trend in big data, you have cost of storage coming down, you have artificial intelligence layers that are going to become very inexpensive to run on big data sets. All of these things should reduce cost, whether it's in the most expensive populations or it's in the least expensive. I believe everyone's going to benefit from these trends that are happening across the board.
So it's less about that specific patient population and more about changes to the system.
Yeah, I think there are some big data trends that are primarily going to change the structure of the cost side of the mechanisms that will facilitate everybody in this room doing things that probably weren't possible, 3, 4, 5, 10 years ago for sure.
Anish?
There is a kind of a challenging commentary about, this is a tech panel, but what I'm about to suggest to you is that there's a really unspoken but more fundamental challenge here, and that's the challenge of culture. And I want to just share 2 vignettes that might set the stage for why, even if we unlocked all this potential, the actions that it will compel won't necessarily happen because of the system's current operating model. And culture, I think, is the single biggest barrier to us unlocking the value of what we think all of this capability will offer. So let me give you point number 1. In the first term of the Obama administration, in the Recovery Act, we had authorized something on the order of $35 billion to digitize electronic health record systems in doctors and hospitals. And by the way, to give you an interesting little anecdote about this, even systems that were digital, we had an advisor, the CIO at Partners Healthcare, John Glasser, during the transition came in and said, by the way, I can't run the simple query of who are my patients that smoke, because smoking status was not a structured data element that would allow for a query to be run, even though it was digital. So we embarked on this journey. We're in the middle of this journey to digitize the systems. But culture came into play, Dan Diamond. One of the areas that we felt compelled to obligate doctors and hospitals was that patients should be given access to their information in electronic format. And specifically, we went to hospitals because they were more mature on the adoption curve than the physician's offices. We said, okay, after every discharge, we want 50% of all patients to be able to access their discharge instructions in an electronic format within 3 days. We thought this was kind of a low bar. And the results came in the Meaningful Use program, and I will tell you, it was sort of about as depressing as it gets. 90+% reported that they could meet this obligation. So we might say, yay. A majority of hospitals wrote an asterisk when they submitted their quality measures. And the asterisk was, not a single patient requested a copy of their discharge instructions. These are some of the biggest name health, and the beauty of open data, Dan Diamond, is that you can look up all the hospitals in the United States, even our friends and loved ones that go to the best and the brightest on the US News rankings, and they would say, oh yeah, we had 50,000 discharges last year, not one requested it. Well, here was the loophole in the reg. The reg said you had to provide the data if requested. How many patients knew that they could access this information? Yeah. Culturally, you would say, hey, new opportunity. We could email it to your Gmail account. We could send it to a secure location. You can log into our portal. Did we as an organization, as a system, embrace this and encourage patients to take access to this information? If the majority of hospitals said not one requested, we have a culture problem. And what I will say to you is that the next kind of extension of this culture problem is, let's assume we've done the big data analytics and we've said, gosh, this patient could get a certain therapy that's cheaper than the path we're on. We already have countless examples where this is known. You could have Excel and a goal-seek formula. Right? You don't need sophisticated modeling to see, oh, this patient could be treated with this option. It's lower cost. Well, gee, we had a conversation with the leadership on the medical staff, and they just weren't interested in pursuing the intervention. And we were just having a hallway chat. I'll make it even more tangible, and I'll leave you with this example. I was teasing him. We made this thing open data sets. We published all the CMS spending data. Every nickel we spent on doctors in the United States is now public. And anyone know the specialty that had the #1 paid doctor in all of healthcare? Which specialty got the highest?
Orthopedic surgery?
Psychiatry.
No. Ophthalmology. So it turns out there's a drug you can inject if you're at risk of going blind. If you've got macular degeneration, we can inject these magic drugs. These magic drugs can forestall your going blind. And they're, branded drugs. These are $3,500 a shot, and you got to get the shot every, 6 to 8 weeks. Dan Diamond, the NIH fielded a study, published not once, but they repeated the study, that found a generic drug was, quote, clinically equivalent, a $50 shot of Avastin in comparison to the $2,500, $3,500 shot on Eylea and Lucentis. What's the current distribution? This has all been in the public domain since 2009, 2010. It is 85% branded, 15% $50. Here's the kicker. This is billed under the Part B program in Medicare, which obligates patients to pay 20%. About 15% of patients either have no supplemental insurance or have a supplemental insurance plan where they got to pay a share. Now sit in the shoes of a patient who's just been told you're going blind, but we have a miracle drug. I'm going to inject this. You'll pay everything in your life savings to avoid going blind. Who's obligated to tell that patient that there's a $50 injection, and here are the doctors in the US that are predisposed to deliver that injection? Dan Diamond, I ask you, are we seeing a shift for the lowest cost, the lowest income patients who bear this burden? Are they being routed by our system today to doctors who already prescribe the cheaper thing in their given city? And I say to you, Dan Diamond, the answer is no. We have work to do in culture. Culture in treating patients with the respect that they deserve, to embrace the opportunity to bring their data and to share it with Dr. Murphy's system, as well as to organize the delivery system so we can optimize to the patient's need. The concept of this big data, digital Hippocratic oath. We now know the information. Are we obligated to act on said information? And I think these are the cultural challenges we're going to have to tackle.
Yeah, I would, maybe I can just carry on. Okay.
And you don't have to say my name repeatedly unless you want to.
Wait a minute, I wanted to do that. I just would like to.
What's your,
Shawn Diamond,
does
Fred
anyone
Smith.
not know Dan Diamond?
Dan Diamond, I tell you.
This is actually how things were.
Listen to his podcast. It's the best podcast in the industry. Go ahead.
I do
Anish
think
appeared on this
I do think
podcast.
the cultural issue is a real important one, and we tend not to focus enough on that. So, again, we can all look to examples where we know what to do, but we just don't do it. I think culture is sometimes, the word that can be substituted as incentives.
Yep.
And it turns out money matters. So I think from a cultural change perspective, we've got things that need to happen on the provider and the provider side, and I think what payers do to either put the risk on the provider or provide the incentives for the providers to do the right thing is very important. And I think there's also a cultural change on the patient side, and I think this is where Robin's comments about digital health and wearables and Fitbits and diaries and all of that sort of online kind of capability can really help move the needle in terms of patients getting engaged with their own health, and to some extent that will help to move the needle on culture. I think the other point is big data helps us understand patients in a much more granular way than we used to. And you don't need to know the name of the patient to know a lot about segments of patients. So to your point about discharge instructions, and does the patient when they're discharged have the follow-up visit with their physician? Do they fill the first prescription that they're meant to be filling? These are all very knowable things, as you point out, and we have enough big data that we can segment the types of patients who do and do not follow the instructions such as they are when they're discharged from the hospital. And we can tailor the interventions. Are they going to respond to a text message? Are they going to respond to a telephone call? Are they going to respond to $5 of some sort of a monetary incentive. What is the mechanism that they're going to respond to? We can go a long way to apply the sort of consumer analytics that now exist and which are being used in other parts of society to help change the culture on those patients.
So two things. First, there's about 15 minutes left in this panel. I think we'll be opening it up now to questions. There will be runners with microphones. If you've got a question, please raise your hand. And again, question, not story, unless you can kind of work it in. And while those hands are going up and microphones are being distributed, my quick question to you, Murray, you're at an organization, Quintiles IMS, they merged last year. Do organizations need to have scale to really tackle big data challenges?
What they need is experience, which comes with scale. I think it's increasingly clear that working with big data in healthcare is a bit different than working with big data in consumer goods or retail or the financial sector. So I think it's a combination of the sort of typical big data, predictive analytics, machine learning, artificial intelligence, augmented intelligence kinds of skills on top of understanding of how to deal with healthcare data. I think, and to that extent, I think scale definitely helps.
Okay, it looks like we've got a question right over here.
I brought up one of the exchanges in Rhode Island, and one of the things that has bothered me a little bit about the conversation is that there isn't a recognition that what we're doing with the data is we're doing things to people, we're not doing things with people, and the entire conversation has hit on plan design and coverage, and I'm not talking about it in the 1,000-foot level. I'm talking about it from the bottom up, what the consumer actually experiences with the payment models and how that relates to all of these pieces. I don't hear that at all. I heard glimpses of it from you and a few glimpses of it from you. But there is a huge opportunity to link those things together, which is something that we've been trying to, or we haven't been trying, we've been doing. And somehow that connection is not happening because everybody's talking about how do we get them to do what we want them to do with no understanding of what that means on the ground.
Yeah, I mean, my own, just on the consumer side, what I would say is that, well, first, I believe that consumers, if you're building a product, say a mobile experience or a web experience, that the consumer is essentially what I'd call voting or giving you that feedback in real time, right? So for the most sophisticated applications in the market, like I used Uber as an example, there is a tremendous amount of real-time data that consumer, from an interaction perspective, is giving to continuously improve the experience. Now, I'm not saying that everybody that's in the application development environment is using that actual experience of what the consumer is sort of doing and then interpreting that back in from a design perspective to change the product. But I feel like in the world that we live in right now, from a interaction perspective, like it is a very rapid way to collect, and you can do that through a number of things. Like it can be digitally delivered surveys, all of those things. Absolutely. I agree in healthcare, it's not happening. I agree in healthcare, it's definitely not happening. In the consumer world, like in consumer applications, I would argue it's happening every single day. Yeah.
I totally agree with that. I'm saying in healthcare.
Well, and I couldn't agree with you more.
One just practical counterpoint, why I mentioned the need to link small data. We're about to enter open enrollment where seniors are going to be purchasing prescription drug plans, Part D plans. And when you go through the experience, even in a digital platform, the very first screen is, please enter the medications you're on. And I've been asking platforms, and their answer to me is, the number one button they push is skip this step. And then they go straight to the list of plans, sort by premium dollar, not the expected spend based on my historical pattern. And all the economists have said we leave between $400 and $500 on the table because the average senior screwed that up.
What you're saying in that example is if the latest consumer technology was used, that person would simply take a picture of the medication and it would go in immediately.
Well,
right? Isn't that what you're saying before?
That is possible, or more realistic, you would connect, given your history with Matt My
fair
Fitness.
enough, yes.
Here's my medications history. Click to connect, so
Yes.
it preloads.
Yes.
The same way I authorize my Facebook data be shared with
100%.
my whatever, pick your favorite song app, and that linkage, that's the spirit of the opportunity with the health internet. It's doable, but
Very doable. Yes.
that was my cultural point. You got it.
Let's go to another question back over there too.
So a follow-up question actually about culture. Coming from the UK and having worked in Europe, I think there is much more of a culture for individuals to share their health data, but often it's built into their healthcare systems. You don't have any choice. One of the reasons I think that big data hasn't been so successful in the US is, and I understand some of the privacy issues, but the linkage you were just talking about, all these tiny little data sets, you can't link them if people are unwilling to share some of their personal information. How can we help change that culture?
Could I make a comment about that as well regarding Europe? Just in the clinical trial setting, it is much more challenging, as you're well aware. They're country-based. In Germany, I don't want to point out as the biggest problem, but they're an example where it's very difficult to get clinical trial data from Germany, even though the patient has consented up to a point of allowing it. And so culturally there with policy, there needs to be a global impact of where we really, what data will you allow to share in whatever setting. In this case that I'm referring to, obviously, it's in catastrophic disease, hopefully understanding and curing it. And the willingness there by far of cancer patients is, what do you need? Here it is. But we need to actually societally really discuss that and noise it about. Thanks for that opportunity to comment.
Not to double down on this, but Francis Collins either spoke already or will speak, and I want to just make a reference point here. We need to make consumer-directed exchange work. So in the NIH program for precision medicine, the new All of Us campaign, they've created basically two pathways to enter. Your doctor or hospital can enroll you after a consult, or an app in your hand, you can directly pull your data, it's called Sync for Science, and pull it out of the system that treats you and deposit it directly into the program. I think roughly 40%, if I hear Dr. Collins' last comments, 40% of their expected enrollment for the 1 million lives will come from a direct consumer enrollment. That's a culture change.
Yeah.
And I believe this, getting the systems to enable that, make that feasible, and a marketing campaign to make awareness under the precision medicine should shift the move on all the other areas.
Other questions? Looks like one over here. Just for time, let's keep moving.
Thank you for the great panel. The question is, like we talked about the need of active data, passive data, data from a variety of different sources to really get a feel on prevention, treatment, outcomes of diseases, right? And one of the issues was availability of the data, and especially from a patient point of view. So like, where you see new technologies such as blockchain that address issues as, privacy, and there are smart contracts and everything else, what your guys take on use of those technologies to unleash the power and empower people to actually contribute their data to all the above, areas of research?
Marty?
Yeah.
I'm not too eager. Blockchain is a tremendous opening for the ability with blockchain to hold the genomic information on a patient privy. All of our data in Project Datasphere, the reason why it's open access and you can go in and study it is because there's patient privacy. It's all de-identified. If and when you link the patient's genomics, especially if it's germline, with that otherwise clinical data, it's impossible to actually make that de-identified. It's impossible. your fingerprint, your genetic fingerprint is there. But we're losing the golden opportunity of having this genetic information for research. So blockchain is going to be used. A fellow by the name of Andrew Lo, L-O, MIT, School of Business. Watch him. He's going to win the Nobel Prize, if not in economics, in medicine, because he's helping us on that. Yeah, at MIT. It's great.
Yeah, I would just add that blockchain is an enabler to no longer require data to be sort of physically aggregated, but to remain distributed. It's still got to be platformed in a way that it can be accessed. There are already platforms. I mean, we have some of those that work today that can link data on a non-identified basis, but find the same patient in multiple settings. Blockchain, I think, just really will transform this and make it much more easy to be able to access the data when you need it and for the purpose you need it for.
In the next year or so, it's going to be scaled. Right now, I know, Murray and ourselves are, maybe not you, but we are anecdotally working at this, but it's only anecdotal. But as we get better at it and more data is going to be applied through blockchain, we're going to scale. And at the speed we're going, I bet in a year when you ask that question, we'll be able to give you hard data.
Yeah, as a follow-up, we're doing very interesting project that we actually use blockchain to give more power and incentives to people who actually should own the data, patients.
Yeah.
So there are we talked about the security, but there are some other dimensions that blockchain will be just amazing technology to use for. And I'm as excited as you are about the potentials.
Last week, we were invited to go to Fort Meade. I've never been to Fort Meade. And you're only, if you're a member of the NSA, do you get on site. And so we went to the NSA and talked with the commander of the research beachhead.
Are you allowed to say this on stage?
Yeah, it was exciting. As soon as we, under armed guard, came into the room, and I was accompanied by the FDA, the guard opened the door into this, by the way, you seen that big blue cube of a building? It's all glass, and there are no windows in the inside of the building. I asked, why do you have all that glass? They never answered the question. I've been told that it keeps all the other radio signals from getting in or whatever out anyhow. But as soon as we entered the room, Dan Diamond, you are Dan Diamond?
Yeah, still not.
Yeah, still.
As soon as we entered the room, I hit this red button on the wall and lights popped out of the ceiling that went around red. Okay, no sirens, but it was like living in a fire engine, always on call. And that told everybody in the room that there were the unanointed, and they therefore had to close their books, no use of a whiteboard, no talking. So yeah, there is an opportunity.
Big data to secret data.
Amen. Well, they're really good at picking up small signal out of big data, and they want to use our data sets as fodder for their algorithms, and will then tell us if they have the ability to do what you're actually suggesting. So that's why I think we're going to be able to scale hopefully soon.
I think we have time for one more quick question, but it's got to be a good one.
No pressure.
So my name is Trevor Penning. I'm from the University of Pennsylvania. This conversation has focused so much on precision medicine. I'd like to get your impressions about precision public health.
Yeah.
We have a problem in this country in that unless we have safe air to breathe and clean water to drink, we are going to have environmental health problems that are going to get exacerbated over time. We have GIS technology that we can actually map the most vulnerable communities when it comes to their water quality and their air quality. That then leads to a way to actually communicate that information to communities to affect decision making in terms of permitting that will occur in the environment. And we can also take that census tract data and put it into the electronic medical record for alerts. For example, people could be screened for respiratory disorders if they're actually in an environment in which the ambient air quality is poor. So I think there is a clear way to use big data to deliver precision public health.
It's a great last question. Anish, any last?
Well, I will just make the case that Mayor Fisher in Louisville, Kentucky, took that exact idea as an experiment. He found a startup that put a GPS chip on every asthma inhaler. Walgreens underwrote 1,000 of them to be distributed by doctors to high-risk patients, mapped where the big attacks were coming, and reallocated his public health and environmental mitigation teams to reduce, so that, if I do the math right, something on the order of a 10% reduction in the concentration levels of particulate matter 2.5 reduced asthma risk by 27%. And uncontrollable asthma is like a $3,000 per ER visit sort of scenario. So it's critical to this conversation of linking small data.
Yeah.
It's not genomics, it's just the inhaler to my record to a public health intervention, and that's very much in the opportunity set in front of us.
Yeah.
That's cool.
Well, I look forward to coming back and talking about big data again, or big data next year at Milken. Thank you to Milken. Thank
All
you to
right,
this panel.
thank you.
Thank you.
Thank you. Diamond.